Yeah, that's right. Now you really can't see.
Okay, Jose, we have yourself, Frida, Sally, and Dr. Katz. We've established quorum. You can start.
Okay. So good morning, welcome, and thank you for joining us today for the meeting of the New York City Health and Hospitals Capital Committee. Today's meeting is officially called to order. For the record, please note Mr. Feniosti Peña-Mora has recused himself as chair of the Capital Committee from this meeting. Hence, I will be chairing the committee today. I would like to propose a motion to adopt the minutes of the Capital Committee meeting held on October 18th, 2021. Let me poll each member individually. Dr. Katz,
Yes.
Frida Wang,
Yes.
Sally Hernandez Piñero,
Yes.
and Jose Pagani, yes. So the minutes are approved. Next, we will hear from our Senior Vice President's report, Ms. Flaherty.
Good morning, Chairman Pagan and the Capital Committee members. Our office continues working on establishing our systems and initiating our pipeline of capital projects across all of our facilities as we concurrently plan for future advocacy of capital funding in addition to the $1.3 billion secured over the course of the last years. As one of our resolutions will highlight, we are busier working on capital projects than planned 2 years ago. We are working closely with our system leaders to further evolve our coordinated approach to this capital plan. Overall progress on the bond portfolio is progressing with only one project in early design left, while the remainder of 14 are finishing up design to start procurement. 15 projects are in procurement, and we're carefully watching supply chain trends, which may impact our completion goals. 4 projects are in construction and 1 project is completed. Some projects were canceled based on funding, and we currently have an active portfolio of 35 bond projects. With 5 resolutions today, I'm happy to take any questions prior to the resolutions related to our office.
I have a question. Just when you said that 5 projects were canceled due to funding, does that mean we expected funding we didn't get, or the projects went over budget, or they were delayed? What does that mean?
It's a combination of scenarios, Sally. In some cases, the project's timing wouldn't work with the bond portfolio, and so we reallocated those projects to capital, to city capital. In other cases, the initial concept budget for the projects were beyond the scale once they were investigated to realize that we needed more funding that we could contemplate within the bond funding. And so each project is unique in their storyline, but those were the projects that were canceled based on, scenarios like that.
Okay, thank you.
Sorry, Christine,
Thank you.
just on that point, you mean they were canceled from the bond portfolio, right? That the
Correct.
projects themselves were not canceled. They're just
That's
seeking
correct.
other funding. Okay, thank you.
Yes.
Okay, thank you so much, Ms. Flaherty, for your report. So let's move on to a series of resolutions. You want to get it started?
Sure. Our first resolution is authorizing New York City Health and Hospitals Corporation, the system, to sign a 10-year lease with Coney Island Associates Retail 2 LLC developer for approximately 2,500 square feet on the first floor of a to-be-constructed building at 1607 Surf Avenue between West 17th and 16th Street in Coney Island. The premise to house the Ida G. Israel Community Health Clinic, the clinic operated by NYC Health and Hospitals Coney Island, the facility now operating on an adjacent lot for a yearly rent of $30 per square foot to be escalated by 10% every 5 years, plus a share of increases in developers operating costs, provided that developer will build out the premise to the system specification within a budget of $250 per square foot, rent not to be payable until 18 months after construction is completed, and the system shall hold the 2 5-year options to renew the lease at 95% of fair market value, with the rent over the initial term totaling $787,500. And now I'm joined by Svetlana, our leader at Coney Island Hospital. Svetlana.
Good morning, everyone. Thank you for the opportunity to present. So just a little bit of background on the Ida G. Israel Clinic. Hurricane Sandy.
Excuse me,
destroyed the-
Svetlana, I'm sorry, I'm having trouble hearing. Can others hear?
I'll move closer. Can you hear me now?
Yes,
Wonderful.
thank you.
All right, thank you. So thank you for the opportunity to present virtually. So just a little background, Hurricane Sandy destroyed the Ida G. Israel Community Health Center, which was originally located on Neptune Avenue. And since July 2014, the Board of Directors authorized a license agreement with New York City HPD for the occupancy, temporary occupancy of 7 lots on block 7061 for a temporary clinic. So in May, May 2021, we brought this contract again to the board, which approved a renewal with New York City HPD for 1 year with 5 successive terms for this temporary structure at no occupancy fee. These blocks of space are in phase 3 of the HPD Coney Island redevelopment project, so they will ultimately be redeveloped. There is however, no date of when those projects will start at this point. Next slide, please. In December, just this past December, the developer will finance phase 2 of the Coney Island redevelopment of city-owned land on block 7062, which is right across the street. $182 million investment to create 376 units of mixed-use and affordable housing space will be financed by HPD and HPC. It will have 11,000 square foot of retail space and 9,000 square feet of community facility space. This building is an opportunity for us to secure a future for the Ida G clinic in this underserved community. It will maintain a long-term presence and will allow us first floor frontage space right onto Mermaid Avenue. So this is actually very good space for a healthcare location. So locals, let's go back for 1 second. So what we're looking to do, and we have some local stakeholder support for a smaller 5,500 square foot ground floor space for Ida G, with projected occupancy starting in 2024. Next slide, please. Just to give you an idea of how things will shake out in terms of the current services at Ida G. So today we have family medicine there at about 4,000 visits a year. This is the service we really want to make sure we preserve in a very central spot right on Mermaid Avenue. We have a chemical dependency program, which is about 13,000 visits a year. And we have dental, of which we're very proud with, at 9,400 visits a year. The plan would be to have dental move into brand new space, which is being planned right now. It's actually an expansion of dental services for Coney Island Hospital. It will be on the main campus, and where we're going to be going from about 8 dental rooms in total between our current 2 locations to 9 plus 2 larger oral surgery rooms, so basically to 11 rooms. That project is slated for to be completed in 2023. And then chemical dependency would also move onto the main campus, but this is pending discussion with Oasis. In the new space at 1607 Surf Avenue, which is really right across the street, it's a private ownership building, and that would have our family medicine practice. So that would be adult pediatrics and GYN access. We would have 6. Next slide, please. Okay, so just before we move to the lease terms, we would have 6 exam rooms, a waiting room. With 6 exam rooms, we'd be able to provide family medicine services, and if necessary, depending on what the community needs, we would be able to have sessional specialists come across as well. Next slide, please.
So the lease
So-
terms for this, oh, sorry.
Go ahead.
Sorry, Svetlana.
That's okay.
So
Go
the
ahead.
the terms here include the 2,500 square feet and the address. The initial base rent here is $30 a foot with a 10% escalation every 5 years. This is a 10-year term with 2 5-year additional options, total amount of $787,000 and change. And here the landlord will fit out this simple clinic for us, which will be a great benefit to H&H, as well as from a fair market value perspective, the cost per square foot here is definitely at or slightly lower than fair market value when compared with other recent transactions with other city organizations directly in this neighborhood at $32 a foot for a 30,000 square foot space in Coney Island. And finally, we conclude with the resolution itself that I read early as we were preparing to present. Happy to take any questions of Svetlana and myself. And I do want to apologize. The cover listed Svetlana as CFO. She is our CEO of Coney Island Hospital. We will correct that in the public board meeting.
Thank you so much. Any questions from board members?
Jose, I love this project. I love this clinic. I think it's amazing. My only concern, 2 questions. One, how much square footage does the family medicine component currently occupy? And 2, do you see it as a growth use? And are you occupying enough space? Because 2,500 square feet is a very small amount of space, which you're making great use of. But do you see an expansion need down the road? This is 10 years.
So I could take that question. So we'll have 6 exam rooms. Currently, we only have one full-time family medicine provider at Ida G at the current space. With 6 exam rooms, we'd be able to have 3 running at the same time. So there definitely is an opportunity for expansion of services as needed. Plus, depending, we can play with hours and offer weekend hours. While 2,500 square feet is not a huge amount of space, there's a lot of things you could do with it if you're kind of creative in how you run a primary care family medicine practice. So we think it'll actually set us up very nicely for the future. And we're assuming that with all the new construction around the facility, that there will be additional need, and we'll be able to meet it if in fact that does occur. But it is small enough to make it cost effective.
Right.
So I think that it's actually right in the sweet spot in terms of the amount of space.
Okay, thank you, Svetlana.
Any other questions? Okay, hearing none, then let's take a vote. Dr. Katz,
Yes.
thank you. Sally Hernandez Piñero,
Yes.
Frida Wang,
Yes.
and Jose Pagan, yes. So the resolution passes. Thank you so much. Great
Thank
work,
you.
Svetlana. Looking forward to seeing the facility when it's completed, of course. Take care.
Absolutely.
Go ahead, Christine.
Thank you. Our next resolution, Felicia, do you want me to do the vendor before I read it or after I read it? Okay, thank you, sir. Our next resolution is a request authorizing the New York City Health and Hospitals Corporation, NYC Health and Hospitals, to increase the not to exceed amount for requirements contracts with 8 architectural and engineering consulting firms, namely Array Architects PC, EFH Architects PC, Gensler Architecture Design and Planning PC, Gertler and Wendt Architects LLP, Lothrop Associates LLP Architects, Moody Nolan Inc., NK Architects, and PA Perkins Eastman Architects DPC. to provide professional architecture and engineering design services, the AE firms, and with 5 mechanical, electrical, and plumbing consultant firms, namely Greenman Peterson, Inc., Callan and Lemonson, LLP, Lacani and Jordan Engineers, PC, Lizardo's Engineering Associates, PC, and Loring Consultant Engineers, Inc., to provide professional mechanical, electrical, engineering, and plumbing design services, the MEP firms, on an as-needed basis throughout NYC Health and Hospitals by an additional $60 million above the original $30 million for a cumulative amount not to exceed $90 million. I just do want to point out a slight amendment to the names of the organizations. The MEP vendors and the AE firms, NK Architects, may be changed to Nadaske Copelson Architects, depending on clarification of legal entity name. And the name listed here today as Callan and Lemonson will actually be replaced by MG Engineering, DPC, formerly Callan and Lemonson. And MG Engineering, DPC is the organization we are contracting with. There's been organizational changes in combining those firms. So we will go ahead and start the presentation. Oscar, do you want to tee this up?
Sure. So good morning. So as Christine mentioned, we're looking to increase the not to exceed value of our architectural engineer and mechanical, electrical, and plumbing pool of professional design services. For good reason. We have a higher volume of work. We implemented our bond refinance of $98 million. We've been able to secure $1.2 billion in mayoral funds to be spent from fiscal year 22 to 26. We've also been able to secure elected official funding for about $30 million from borough president and city council funds for this fiscal year. So, and in addition to that, we've been able to secure additional funding for critical, clinical, and high priority projects, such as our Coney Island ambulatory care, our Seaview PEDS facility, and several others. In addition to that, we've been able to secure some DCAS funding for carbon energy reduction and in order to help reduce our carbon footprint. So the ACE grant awards have been issued. It's a good problem to have, which is a lot of work that we did not anticipate has come along, and we've now have to tap into our existing contracts and with a much higher burn rate. And one more point to highlight is that we are also trying to essentially knock out 2 birds with 1 stone. We're using the contracts to do feasibility studies and pre-schematic designs, and if we proceed with the projects, we're also getting that cost estimate from the consultants in order to do the full design work. So essentially, they will do design work, pre-schematic design work, prepare construction documents, help us during construction for construction administration services, independent cost estimating as well. So a quick overview. In June 2020, the board approved the contracts. They went into effect January 2021. So as Christine mentioned, we have 10 A&E selected firms, but we only contracted 8. 2 of those firms we had issues with. 1, we were not able to negotiate terms, and the other fell into some financial woes because of COVID. So we only contracted with 8. As far as MEP, the 5 selected were the 5 contracted. As Christine mentioned, we have a total original $30 million, and we're requesting an increase of $60 million to bring us to a total of $90 million. The A&E, architectural and engineering pool, has the utilization rate of 30%, and they did present a total of 47 NWBE subconsultants to use through the life of the contract. And for the MEP, also 30% utilization plan with 38 MWBE subconsultants within the life of their contracts. Next slide.
This slide shows you our current committed registered work orders that are with the vendors today. So $4.5 million has already gone, with the commitment. And we have over $9 million of pending work orders that are in the pipeline already, leaving us only $3.5 million in the A&E pool left, even despite the fact that these contracts went into effect relatively recently, which demonstrates the need for us to have a vast increase in capacity for these contracts. The next slide captures within the A&E pool the MWBE utilization of our A&E firms. And I'm proud to say across the board, most firms are at or above 30% participation on the A&E side. We are really happy to see a 41% utilization against our commitments of the work orders. And we are carefully speaking to each firm and making sure that they're meeting or exceeding the goals. And we do feel comfortable that all firms will be able to robustly use the 47 MWBEs that were identified in their plan at the time of the board approval in June 2020. Next slide. On the MEP front, this shows you our utilization of the MEP pool. It's not as robust as the architectural, but it is significant. And we do anticipate, as Oscar identified, the need for additional energy reduction, carbon reduction, and ACE grant funding happening, which will, again, result in a demand for higher utilization than originally contemplated of this pool. At the time of these contracts, this was prior to our new OP being looked at on MWBE utilization. I will point out a mechanical, electrical, plumbing project makes less room for sub-consulting out. And so at times, some of our firms have struggled a bit on the MWBE utilization front. We are going to be meeting with one of the firms, Loring Consulting, about their MWBE utilization, which is substantially lower than all the rest. Sometimes this is equipment replacement in kind, and that makes it very hard to identify architectural or other sub-consulting opportunities, but we will continue to look at that. And I think in the future for these contracts, we may have to slightly lower the MWBE goal just because of the nature of the work. But effectively across the pool, we are happy to see a 21% utilization across the whole pool. LaConnie and Jordan is a MWBE firm as a prime, so that's great to see. And we'll continue to monitor this closely. The next slide is our resolution that I read already into the minutes. Happy to take any questions from the committee.
Any questions from board members?
I just had a question about the $98 million on the refinancing. I remember there was a $50 million reserve that was freed up, I think, and then the other 48 million was from, I don't remember.
So if we went to the slide, so we had 98 million was the total value of the city refinance bond, and that's inclusive of EITS and equipment as well as infrastructure projects. We've secured 1.2 billion in mayoral city funding to help support our system since the time when these contracts were originally contemplated. So a much more robust checkbook than we had in the past. And then we also secured 30 million in borough president and city council funds in fiscal year 22. We're happy to go through what those projects are in the checkbook, Sally, should you have specific questions about specific sites or scope or scale.
Okay, thank you.
Of course.
Yep. Any other questions?
Christine and Oscar, so it's great news about all the additional capital funding sources that we've gotten, so that's terrific. And you guys seem to be spending quickly, so that's good, getting projects. I'm just curious, well, two questions. The first is more just technically. So the contract term is not changing. It's the same 3 years with 2 additional options, right? And the amount we're authorizing is for the full 5 potential years. Is that correct? Or that's the expectation anyway?
That is the potential expectation. You know, I think we're going to look at the burn, and if we need to work with supply chain and do a new pool, we will go ahead and do a new solicitation. We did want to give ourselves both adequate capacity to immediately address the new funding that we've received, while also looking at the capacity of the firms that are in the pool. Of note, an example, Frida, is 2 of the firms have been unable to really answer some of the mini RFPs because they're working on the OTX-2 program, which is incredibly exciting and important, but they do anticipate competing in future projects once they wrap up those assignments. And so I think we're not ready to yet say our timing of the new pool, but it might be sooner than 5 years based
Okay.
upon, you know, capacity.
Right. So that was my next question. This is a huge increase, obviously, from what was originally anticipated. We lost 2 of the firms that you'd originally selected. So wanted to see how you felt about capacity, and then also how are you are these just estimates? The going from 30 to 90 million, is that based on the projects that you have identified, or is it simply just a you know, how did you get to the number, I guess is the question.
So we kind of looked at our burn rate a little bit, our utilization rate. We definitely have a robust pipeline of projects that are active. We have projects that are in what we call pre-initiation. So we're kind of vetting out the scopes and doing mini RFPs. And so there was a deep dive of the list of those projects and looking at what we expect the cost of design services to be for those projects. And so it was a combination of looking macro and then looking micro at the project list as well. We do expect to probably fast track our next solicitation and probably burn out of this prior to the 5-year period.
Right. Okay. Thank you. As I said, this is exciting. A lot of good work.
Yeah.
Thank you.
Christine, question that I have for you is related to internal capacity to manage these projects, meaning from your office, also procurement, also facilities themselves, you know, so just to make sure that we have the oversight necessary to be able to do all this work.
Yeah, so we're taking a multi-pronged approach to your question. We are in the middle of doing substantial recruitment and identification of staff. We also are in the process of working very closely with our facility leader partners and actually centralizing a capital lead at each site just to ensure that Oscar has kind of clear line of sight to all projects and that we at central office are supporting the work happening in hand. At some of our sites, we are also looking to deploy construction management firms as kind of dedicated to a site to handle and help and assist a myriad of multiple projects concurrently to ensure that there's coordination among those projects and to bolster our own internal resources so that we can make sure that we can deliver all these projects on time and on budget, and that we're establishing appropriate timelines and budgets as multiple projects happen concurrently without interruption to the most important thing, our clinical services for our patients and staff. So we do recognize with this infusion comes many responsibilities as well as resources in our legal and supply chain teams. We're working closely and partnering with both Danielle and Andy to also increase our capacity on all of the pieces of work that tie to a capital pipeline. And I want to thank Dr. Katz for his ongoing support in this matter as we ramp up our resources.
And on that note, I would like to call for a vote. Dr. Katz?
Yes.
Frida Juan?
Yes.
Sally Hernandez Piñeiro?
Yes.
And Jose Pagan, yes. Thank you so much, Christine. Let's move to the next one.
Thank you. Our next resolution is authorizing New York City Health and Hospitals Corporation, the system, to sign a contract with Consigli Construction Corp. Incorporated, the CM, to serve as construction manager under a guaranteed maximum price GMP structure for the construction and construction management of the system's Outposted Therapeutic Housing Unit, OTXHU project at NYC Health and Hospitals Bellevue. for a cost of $109,925,530, which when added to a 10% project contingency yields a cost not to exceed of $120,918,083. Of note, the vendor responsibility form for Construction Company, Inc. The vendor responsibility was approved, EEO is pending, and there is a 30% MWBE plan. I believe the memo might have missed this package, so I did want to read in those 3 facts that came to me from our colleagues in supply chain. And with that, we will go ahead and get started with my partner, Patsy Yang.
Hi, good morning. I think people, hi, good morning. I think people mostly remember this project, but basically, despite a lot of the innovations that Correctional Health Services has done since becoming part of Health and Hospitals, in terms of access and quality of care, there remains a group of patients who really need ongoing or frequent access to specialty or subspecialty care that's only available in hospitals. But because of the really arduous transportation, which can take 9 to 10 hours out of their day for what may be a few minutes of consultation, many patients decline health-saving and in some cases life-saving care. So we came up with this program, Outposted, an acronym that's really difficult, but it's Outposted Therapeutic Housing Units, which the mayor approved and announced in November of 2019. But despite that approval, because of particularly the deteriorating circumstances at the facilities at Rikers in particular, which I think everyone's read about, certainly since COVID in 2020 and through this year, we've not quite recovered. The urgency of getting these units open and operating to protect our most fragile patients has become just more of an imperative. So this is the project that we are asking for additional dollars and acceleration, both currently at Bellevue, and what this does for the, sorry, next slide, sorry, keep reading that, is that there are benefits to the patients, obviously, in terms of access and quality of care, greater opportunities for continuity of care between the hospital staff and the correctional health staff who will be working together side by side, literally. To the hospitals themselves, there's underutilized space that's going to be repurposed. There's capital infusion coming into the hospitals, not only for the units themselves, but enabling work and infrastructure work that's necessary for those units, as well as operating expenses that will come to the hospitals for these units, and Medicaid revenue. The units will be operated by Correctional Health Services. They are secured units. They are not part of the hospital's operating certificate. The security will be provided by the Department of Correction. And I think that's probably where I stop and hand over to you.
Thank you, Patsy. So good morning again. By way of background, the OTXHU project was publicly announced November 26th of 2019. During COVID, we worked and secured 3 contracts that the board approved in June of 2020, designed for OTXHU at both sites, Bellevue and Woodhull, with Array Architects, program management services as an extension of staff of H&H to help us manage design and the whole portfolio with Acom. And then there also was a design service contract for what we call enabling projects, which is relocations of multiple spaces at Woodhull to open up and free up space of OTXHU. Design is well underway, wrapping up at Bellevue, and we advertised in an RFQ for construction management services in the fall, and we were expecting to deliver Bellevue by 2023 when we issued the RFQ. Based on the conditions, as Patsy mentioned, at Rikers Island, it became an imperative to really compress this schedule substantially and bring it to a completion of next calendar year. Recognizing this, we looked closely at what we were planning, and we really looked at all of our options. We received a waiver to allow us to do construction management at risk in a GMP model from the mayor's office, and we pre-qualified the firms and identified an RFP process to bring somebody on board, recognizing we are shortening the deadline for calendar year beneficial occupancy of 2022. In order to do this, we compressed our purchasing timeline with our partners in supply chain, and we received capital funding for what was needed to ensure the schedule compression did occur in the September plan. And so I want to thank OMB for their support as well. The OTXA2 project itself, importantly, is to kind of show you the floor plate of what we expect to do on this one floor at Bellevue Hospital. We have 114 patient beds, as well as treatment areas, and it's about 64,000 square feet, 45,000 of that being clinical space, the rest being circulation, core, support, and admin spaces. This will be a full gut renovation of all the space itself. We are going to be also replacing all of the windows on this floor. And I failed to mention on the background slide, we also are replacing the roof of Bellevue Hospital H building as part of this project, which is going to be shown on the next slide. What is incredibly exciting about this project is really we're creating a wonderful environment of inpatient or outpatient for this population. And I hope that this is one of many projects at H&H that help address our behavioral health units that are, frankly, we'd love to do more of these types of projects and create a normative environment that really improve the clinical outcomes for patients and staff. Next slide. The next slide shows you actually the outdoor space. This space is required to ensure that the patients have access to outdoor space. And so this will require a full revamp of the existing forensic space that is on the roof of Bellevue. And during the early phases of looking at this project, it was realized that the roof itself needs a full replacement. And so we've integrated that into this project as well, replacing the roof, because without that, we can't create the recreation space on top of it. This is going to give a great benefit for the patients to have fresh air and have daily exercise should they opt for that option. Next slide, we're going to cover the scope of services of the CMGMP provider. They're going to really look into the project itself and the drawings and provide any recommendations on the bidding strategy. They're going to fully procure and enter into contracts for all areas of scope of construction, FF&E, and equipment. And at the early stages of their contract, they'll be working on our behalf as we work towards keeping the project on target and in budget and accelerating the project. They have all of the subcontracts with all of the vendors that will be working on the site. They're going to have an MWBE program that is robust, that ensures 30% is met or exceeded. And they have full coordination of all the trades, all of the payments, all of the quality of the work, and everything for the project to be successful. They're responsible for logistics at the site and ensuring that they deliver a logistically sound plan for Bellevue Hospital's sign-off. Already we've worked closely with Bellevue Hospital, and in the schedule compression, we will be working 24/7 to ensure that this project is completed this coming calendar year, but that requires incredibly close coordination so as to ensure no impact to the patient and staff environment. It is helpful that this floor is not above or below inpatient settings. It's office settings as well as ambulatory settings above and below. And the site will have a dedicated second entrance on the northeast portion of the H building that will help ensure that there's a minimal impact to the hospital operations. During the project, H&H and our program manager, Acom, will have a robust role of overseeing, approving payments, and ensuring that all the quality of work is complete by this CMGMP firm. The terms of this contract, the funding is coming from city capital. This is a total not to exceed $120 million as mentioned, as I read in the resolution. 10% of that, $120 million, is actually contingency that is not going into their construction contract that we would sign. Their target budget contract is $109 million and change. The duration is 13 months with a contract start of December 1. They'll have a warranty period that could range from 1 to 2 years, depending on if they have to repair or replace any items once the space is occupied. And so the longest term of the contract could be up to 3 years for long-term closeout or warranty items. Next slide. Now I'm going to cover the solicitation itself, the RFQ and RFP timeline that was compressed substantially. CRC approved application to issue RFP and RFQ in July. In September, we posted the RFQ. It went to all city record as well as outreach to 17 vendors. There was a pre-submission conference on the 14th of September. The RFQ deadline happened on October 4th, and 5 proposals were received. Swiftly, those proposals were reviewed, and vendors were shortlisted. 4 firms were shortlisted. And then there was a walkthrough at Bellevue Hospital on the 12th of October to start reviewing the RFP content, and the RFP, it was issued with a contract on the 14th of October with a proposal deadline of the 29th of October. The RFP included construction drawings, 50% construction drawings. And so the vendor had to look at the pricing and create a budget for the project, as well as a detailed technical approach. The evaluation committee interviewed proposers on the 3rd of November and ranked the highest scoring vendor, Consigli Construction, as the highest rated proposer. Next slide is the criteria that was used for the selection. 35% was proposed approach and methodology, 35% was appropriateness of quality of firm's experience, 15% was the MWBE utilization plan, and 15% was cost. The evaluation committee members included individuals from Bellevue Hospital, our colleagues in EITS, 2 members of the OFD team, a member from supply chain, and a member of correctional health services. Consigli Construction is an employee-owned construction management firm with more than 1,500 employees, 9 regional offices, and $1.8 billion in annual revenue across the various markets. They actually, 25% of their experience is working in healthcare, and they currently have over 40 healthcare clients. They really demonstrated an ability in their approach and innovation of their proposal of thinking through how to fast track this specific projects. And we actually are excited. We do not have direct experience working with Consigli, but they have experience locally with Northwell, SUNY Stony Brook Medical Center, and Albany Medical Center. So this is an opportunity to work with a new partner that we believe will succeed in delivering this fast track project. They did in the proposal demonstrate a robust MWBE utilization plan. As mentioned, they will be bidding out and awarding many subcontracts to deliver this work. And in their approach, they actually listed a large number of MWBE firms for specific scopes of work that showed the 30% goal. They also had NTech Engineering, PC, and Padilla Construction, both a WBE and an MBE as part of their core services within their approach, in addition to identifying a number of trades that they would either have full MWBE participation or up to 30% MWBE participation for that specific package. Next slide. So the next slide is our resolution for the award of this contract. We're happy to take any detailed questions any of you may have. Thank you.
Thank you. Any questions from board members?
I think this is both of these are awesome projects, helping not only relieve the strain at Rikers, but helping very vulnerable members of the Rikers population. But it is an incredibly expensive project. This one is compared to the other. Is it that much more expensive because of the roof work that you're doing, Christine?
So I would say there's a number of aspects of this that makes it expensive. We do think that this is both correctional space and it's behavioral health space. So there is a high degree of specialization of the type of built environment we're creating here. We have hardened wall systems, secure systems, We also have new windows that are being installed within the scope of this project. And so this is highly specialized, I would say, as far as the type of building materials that have to be used, and everything from the interior walls to the security ceiling system. Every aspect of this has to be ligature-free, has to be tamper-proof. And so you're dealing with a very specialized built environment that we're creating.
Mhm.
I would also say that some of the cost here is that we are compressing the schedule, and we're going to be working a double shift so that we can ensure that it's complete as quickly as we can make it. And so that's another aspect of what can drive construction costs up. And also we're doing this all within a existing operating facility. So there's other elements here that are, complexities that cause more coordination, more people power to ensure that it's done carefully, that we're threading the needle and not impacting patient and occupants environments.
So is Woodhull similar in terms of the client population, the extra construction features that you need to add? I mean, I'm just comparing the two. I'm trying to understand why one is so much more expensive.
I would say that, we can kind of go through and debrief you after the costs of each project. There is an increase from this project's original budget. The increase includes schedule compression, the addition of the roof replacement, and Woodhull has its own sets of challenges of that location, and I don't know that Woodhull is substantially less expensive because you have the same key features that are being added. We also had to secure, and we received dollars to replace the roof at Woodhull. We actually had a similar challenge at both sites. And so I don't know that, I don't believe at this point, and we'll look at the numbers carefully, that one is less expensive than the other. Woodhull is larger. It has actually more floor plate and more beds.
Okay. And then I just had a question for Patsy. I'm not real clear on what therapeutic housing is. Are they going to stay here as patients? Are they coming for some period of time and then going back, like for a number of days, and then they go back? Not sure what it.
Yeah, thank you, Sally. Similar to the therapeutic units that we have in the jails, the patients actually will live here. So it's really, when we say it's a pioneering project, it really hasn't been done yet. It's a bit of an aardvark. It's both health and security. It's neither inpatient nor outpatient. It is where patients who actually need access. So there might be an active cancer treatment, for example, and so they will live in these units for the duration of their treatment, and regularly access care in the hospitals until they are either released from custody or they reach a clinical status where they can be returned safely to jail.
See.
It is a jail unit within the hospital.
And the behavioral health patients are just long-term behavioral health patients?
So these units are for medical patients with medical conditions, mental health and substance use conditions. Most of the latter will probably have comorbidities. The bulk of these are medical patients. These aren't mental health units, for example. Although all the ligature, all the things that need to happen apply equally to custody settings, carceral settings. But the bulk of these patients will be there probably until they get released. A lot of the patients who we're talking about are the medical patients who are in our infirmaries. Were they not in custody, for example, while they're with us, we work very actively to get them discharged to an alternative to incarceration or released, and upon release into settings like assisted living or skilled nursing facilities. That's sort of the level of care that they require. They're sort of subacute patients, many of them. Many of the ones who are medical, who have comorbidities, either behavioral health sort of substance use or mental health needs also have medical issues.
Okay, thank you, Patsy.
Yep.
Okay, any other questions? Go ahead. Rita.
Yeah, just following up on that, Kathy, so the units that we're developing here, are these just for the incarceration aspect, or is the medical service being delivered in here as well? The medical care?
Both. When I say they're therapeutic units, in that they are secured units for people who are in detention for whatever reason. And again, these are pre-trial detainees. For the most, 99%, 90% of them are pre-trial. And they have arrived into the detention system with conditions that we have either been the first to diagnose or to begin treating. And certainly, so the care, we Correctional Health Services will actually act as their attending internists, primary care physicians with specialty consultations with the hospital while they're with us. It's just, rather than a 9-hour multiple vans into facilities ride, it might be an elevator ride away, or ideally the specialist will come to the unit itself. So the difference also is it's neither outpatient in that they come to a clinic and then go back home where they live, nor is it inpatient where they're literally just more or less, in acute bed bound. They will live there. It is their residential area, but certainly Correctional Health Services clinicians are embedded in those units. We do our job in there. We don't come in and out. And the specialist will probably come to the unit. If that helps.
Thank you. I agree with Sally. I think this is really amazing, and the aardvark, as you put it, is going to be very interesting. And congratulations.
Thanks.
Just a couple questions in terms of the separate entrance. Christine, is there separate elevators, or is it just from a literal entrance to the building that's separate?
So we're in the middle of, once this contract's approved, one of the early work packages will include substantial sidewalk bridges going up, as well as actually a dedicated, I believe we landed with a hoist that will be going into and entering the second floor for the workforce to kind of go in for the construction phase. And so that's going to be on the northeast side of Bellevue Hospital. Bill and the team identified kind of a spot that they could stage. And that's really for the construction to be enabled. And then from an operational perspective, Patsy and Mr. Hicks have identified kind of operationally the entry and all of the entry, and Patsy can speak to it more clearly than I can. There's always escorts for a patient coming into the space.
Just very quickly, as Patsy, the beauty about Bellevue is that they already take care of our acute hospitalized inpatients on the 19th floor. So the traffic pattern and flow is already well established, and is fairly segregated from the rest of the hospital, so that it's well worn.
Okay, and I think it's great that actually, Christine, some of the other work is getting done as well that is going to benefit the system in terms of the roof and whatnot. And some of the specialized construction that you talked about, is that really just for the second floor for the unit, or does that mean the whole building needs to be reconstructed? Not at all.
No, I guess I was going a little bit on a tangent in that there's definitely an opportunity to work with Dr. Barron and our clinical leaders. Many of our behavioral areas have not really undergone renovations, and they're hard units to renovate because they have to be unoccupied. They tend to be busier units. And so it is like a long-term goal of ours to really look at creating a more normative care environment that's in the current century. I think they do a great job, updating in an emergent kind of way the repairs to do the best we can. But I do think that it is in our interest to look at long-term planning to help support those units.
Right.
Not just forensic, but behavioral health.
Right. And last question is just on the amount that's approved in the city capital plan. Is that for the full amount, including the contingency?
Yes, we
We
have
have-
adequate funding for this amount.
Okay, terrific. Thank you.
Thank
Okay.
you.
Thank you. Then let's have a vote. Dr. Katz,
Yes.
Sally Hernandez Piñero,
Yes.
Vida Juan,
Yes.
Jose Pagan, yes. So resolution is approved. Let's move to the next one, Christine.
Thank you. We'll have one presentation for two resolutions. The first resolution authorizing New York City Health and Hospitals Corporation, the system, to increase funding by $6,087,369 for its agreement with Acom USA, Inc., Acom, to provide program management services for the preparation of space at NYC Health and Hospitals Bellevue Hospital, Bellevue, and NYC Health and Hospitals Woodhull in connection with the system's correctional health unit initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units in Bellevue and Woodhull, such that the funding is increased from $9,039,198 to $15,136,567. So we're going to go through the first couple of slides here are actually a repeat of what Patsy did an amazing job of presenting, the importance of OTXHU, and also a background on compressing the schedule substantially. And when we compress the schedule, the existing consultants that serve us also need additional services to make that happen. And so the next slide will cover Acom specifically, an increase for funding for Acom's scope of services. As we looked at the schedule compression, Acom is on board as our program manager. Extension of our team have been helping us manage our design consultants for both sites. And as we looked at the schedule compression needed, one area of work that we had already contemplated doing was really getting abatement and demolition services going at Bellevue Hospital. We asked Acom to directly manage that. At the same time, we were getting the construction management firm up and running. And right now at Bellevue Hospital, construction is underway on the second floor to demolish and abate the area, getting ready for consigli to arrive should the contract be approved. Additionally, as we mentioned, the construction is going to happen at double shift. That means we have to oversee that. And so Acom really staffs up to support us in this endeavor. And that requires them to have additional staff and manage this type of CMGMP contract and help us on the reviews and make sure that we meet the schedule goals. And so this covers the scope of services of Acom's contract. The next slide will cover the fee here. This is specifically only for the Bellevue project. This is a schedule of 14 months from October to February of 2023, increasing their not to exceed value, which is really tied to a staffing plan that would only be used upon people showing up for the project and working on the project. And so this is a not to exceed budget that will be spent as people are approved and arrive on site. The MWBE participation for this amendment demonstrates 32.5% participation of staffing. They're going to be ramping up substantially their MWBE vendors for the total contract value of $15.1 million. Originally, their MWBE utilization plan was 30%. This amendment will bump their effective increase to around 31% in total. And I would point out that their contract was fairly recently registered. They worked at risk for over a year, supporting us on getting this project going. And in doing so, they did not bring on a large volume of MWBEs at the early stages of their work. And so currently on the invoice side, they're at 10% MWBE utilization. However, we do expect them to meet the target of 31% for their total contract value now that they had their contract registered and MWBE professionals are showing up as part of the project team. Next slide. The next slide is the resolution language itself, which I read into record already as a request to increase Acom's contract capacity.
Thank you,
Happy to
Christine.
take questions.
Any questions from board members? Okay, so let's then have a vote on it. Frida Wang? Yes. Sally Hernandez Piñeiro,
Yes.
Dr. Katz,
Yes.
and Jose Pagan, yes. Let's move to the last one then.
This is our last resolution. I lost my language. Hold on a minute. I'm sorry. I have too many. Authorizing New York City Health and Hospitals Corporation, the system, to increase the funding by $1,814,880 for its previously executed agreement with Array Architects PC, Array, to provide architectural engineering services for the renovation of space at NYC Health and Hospitals Bellevue Hospital, Bellevue, and at NYC Health and Hospitals Woodhull Hospital, Woodhull, over a 5-year term in connection with the system's correctional health unit CHS initiatives to treat its patients who require higher levels of care in its outposted therapeutic housing units, such OTXHU, such that the funding is increased from $8,663,000 to $10,477,880. So the scope of services here, this is a specific increase for Bellevue Hospital's schedule compression. The original scope of services were AEMEP design consulting services, inclusive of all of the areas of work. With the schedule compression from fall of 2023 to December of 2022, we really wanted to leverage the best practices we learned as we executed a high volume of emergency projects throughout the pandemic. That means our designer is next to us, along with us, with our contractors, making decisions on an expedited basis, co-locating with our contractors and our construction management team to make sure that they have guidance and direction, and there's a technical understanding and a respect and understanding from our design professionals. And so 2 areas of scope that are increased through this amendment. One, Array Architects now needs to design a brand new roof. So that was new funding we just received. So there's a new roof, and so there's an expedited design of the roof itself. And with the new roof, it now is a full revamp of the outdoor space because it has to be brand new. It can't be refurbished. And so there's that scope. And then there really is an additional staff co-located and an accelerated turnaround on submittals and RFIs that happen in the early stages of construction that the vendor needs to ensure that the components and parts that are ordered are approved by the engineer and architect of record. This is incredibly important, especially with supply chain concerns for this project. That is probably our most concerning risk of this schedule. Our consigli, our CM, really identified the goal of having everything purchased by May, and actually they're planning on renting a warehouse in Long Island City just to ensure that we have all of the materials we need, and the designer playing a role of approving all of those elements and parts that are available will be a key part of this discussion. And so that's why we really needed to ensure that we had enough A&E resources for this project. Next slide. The MWBE plan here is robust. Array has had a plan in the original contract of 36.4%. Invoices to date, they're at 42.5%. For this specific amendment, the design of the roof replacement is done by their partner Urban Architects, and they're not an MWBE. So in this case, the amendment itself has a slightly smaller MWBE participation, but there still is a plan of 17%. And that brings us to an effective contract value of MWBE utilization still at 33.1%, above our 30% goal as an organization. So we are comfortable with the plan that Array has presented us. And the last slide is our resolution itself.
Thank you, Christine. Any questions on this?
I just have one question, Christine. Actually, this is really probably for the prior one. The funding, it says the request is forthcoming. So is that you have the increased amount requested to the city and that you're waiting for approval? Is that what that?
Oh,
refers
yeah,
to?
so we have budget in our mayoral funds for this, both of these resolutions we're presenting. We are in the process of getting our capital proceed to OMB to codify the funding for this. But yes, the funding is in place in our budget.
Okay, for both contracts, the Acom
Yes.
and Array. Okay, that's it.
Correct.
Terrific. Thank you.
Thank you.
Anything else? Okay, let's then have a vote. Frida Juan, Sally Hernandez Piñero,
Yes.
Dr. Katz,
Yes.
and Jose Pagan, yes. So the resolution is approved. I think this is it, Christine, right?
Yes, that's it. Thank you so much. We're
Thank
really
you.
excited to keep this project going, and we look forward to presenting to the full board on Thursday.
Thank you for all the work you and your team are doing. This is incredible. So any old business to come before the committee? Any new business? Okay, so the committee meeting is adjourned. Thank you so much. Have a great day.
Thank
Thank you,
you.
everybody.
Take care.
Bye-bye.
You all.
Bye.
Take care.
Great morning.
Bye.